and welcome to this conversation. I'm Jasmine, I'm the Hematology Oncology Fellow at the Cleveland Clinic, and here we are today with Dr. Park for a discussion on a presentation that he presented at San Antonio Breast Cancer Symposium about early detection and molecular recurrent disease. Welcome. Would you like to go ahead and just give us a brief overview of your presentation?
Yeah, so presentation was a little bit different this year because what we decided to do as a panel, so it was myself, Dr. Heather Parsons, who many people don't know was actually a fellow of mine in my lab when I was at Hopkins, as
Yeah.
well as Dr. Dave Sisson and Heather's at Dana-Farber and Dr. Sisson's at University Hospital, well, really Princess Margaret Cancer Center at University of Toronto. And then the moderator was Adrian Lee. But what Adrian did, he also introduced a patient advocate. But what we did during our planning meeting, what came out, rather than just giving lecture after lecture, when Ellen gave her whole history of breast cancer from diagnosis, treatment, and then kind of nothing happening, some monitoring, and then 20 years later getting a relapse, it really
Hmm.
spoke to Dr. Lee and the rest of us about how liquid biopsies and circulating tumor DNA could really make an impact on disease today, where it couldn't when she was originally diagnosed. And we still have room to grow. And so
Hmm.
our conversation and talk was kind of split up into background, different tests and platforms, et cetera. And then we had a panel discussion. But within that larger context, an area of research interest of mine across the ctDNA spectrum, and specifically in breast cancer, and metastatic disease, but really something we've been pushing for was this thing that you had mentioned earlier about earlier detection and MRD.
Hmm.
And so just as a background, if you don't know what cell-free DNA is, it turns out biologically all the cells in our body shed kind of free-floating naked DNA into the bloodstream, and it usually just gets filtered out and excreted as urine and as metabolized in the liver as well, or chopped down. We don't think it has a function, or nobody knows that it does. I think it's cellular waste. I call it cellular poop a lot. And then what we now know is that cancer DNA, right, has tons of mutations, structural variants, and so those are different compared to the rest of the normal DNA. And so we
Hmm.
know most of the cell-free DNA compartment is going to be normal from normal cells that are shedding their DNA, and then a small fraction is going to be coming from cancer cells. And so that becomes the surrogate biologic marker of liquid biopsies or circulating tumor DNA. So ctDNA is just a subset of cell-free DNA.
Hmm.
And what we've been trying to do for many, many years, really literally about 15 years, is to figure out, can we develop tools and studies that allow us to confidently detect this so we know who is actually cured of their cancer and who is not. We're not
Hmm.
quite there yet. We probably know at this point with technology and studies that we know who isn't cured, right? But we still don't know whether or not we can cure those patients by giving them additional therapies. We hope so. That's the focus of ongoing trials, some of which we all talked about, and Dr. Dave Sesson showed in his one of his last slides. But we have a long way to go before that actually gets translated into, yes, this will make an impact. And I will tell the fellows listening, this is really the difference between what we call clinical validation and utility.
Hmm.
Validation is, hey, we know that this test does what it thinks it does in patients. But remember, the tenet of medicine that they teach us in medical school is don't order a test if it doesn't change your outcome. And so if we
Yeah,
don't have a way to change the outcome, we're not going to order the test. And there are real examples of biomarkers in cancer where they are validated but had no utility. And
that's right.
this today. So what we're still trying to do as a field is put some utility on this. We know that positive MRD is probably a real thing, and the majority of those patients are going to relapse at some point. So let's design studies to see if we act upon that, can we cure more patients? On the other hand, no tests so far, there's more coming, have a negative predictive value that's high enough to say you're cured. Okay.
Mm-hmm.
And no test is 100% perfect, but we're not even in the like 95 and above percent range yet, which is really what we need. And we're almost there. I dare say we'll probably be there by end of next year or this year, this time.
Yeah.
At least I hope so. And that's one of the things that we did. We did really the first, and I think still only prospective multi-center trial specifically addressing questions of ctDNA validation and a little bit of utility across breast
Mm-hmm.
cancer patients getting neoadjuvant therapy for triple negative breast cancer or HER2. It's through the Translational Breast Cancer Research Consortium. We hope to report those results out next year. But literally, this has been 12, 13 years in the making. Heather Parsons, who I mentioned is an attending at Dana-Farber and researcher now in this space, wrote that protocol while she was a fellow in my lab. That's how old it
Oh,
is.
wow.
Yeah.
Yeah.
But so
That
we're really
vision.
excited about the readout because literally
Yeah.
every patient now has more than 5 years of follow-up. So
Yeah.
partnered with someone who I'm not sure I can mention right now, but they have some pretty amazing technology that looks
Mm-hmm.
very promising.
Yeah, those are definitely very, very promising, innovations, especially what you said. I think I want to echo is like the clinical utility. I think that's
Right.
really important because I myself see in clinic like patients other coming from a lot of patients coming for second opinions or whatnot, like a lot of like ctDNA is being detected and you get imaging, but you don't see any disease on
Correct.
imaging, but you still have that ctDNA, but you don't know where it is. Like, do you change treatment? Do you just observe? But we don't have much data behind it right now. And
Correct.
what do you see, or what advice would you give, I guess, for fellows or trainees in terms of like when patients ask us, um, that yes, I am like I have positive ctDNA and there's nothing on imaging and you're not changing my treatment. Like, what do you recommend us telling patients or if
This is
they,
in
if
the
the
early stage setting you're talking
yes,
about, correct?
mm-hmm,
Yeah.
yeah,
In
mm-hmm,
the metastatic setting, right, we're always ordering this nowadays.
right, yeah,
Sometimes we can get targeted therapies based upon those results. But for early stage, particularly breast cancer, because this has kind of exploded, it's available,
mm-hmm,
patients largely want it and they're asking for it. But
yes,
I have ordered this a few times, but I always have the conversation first. And I actually never
mm-hmm,
order it on the spot. I tell patients you need to talk with your spouse if you have one, your family if you have one, because this doesn't affect just you, it affects everyone. And I've actually seen
right,
this firsthand. So
mm-hmm,
tell them a positive result, you almost have to think about that and we'll scan you, but it'll always be negative. And you almost have to think about this is like a time bomb ticking, waiting to happen. And can you live with that if we can't
yeah,
do anything about it? Now, I always tell them if we order it and it's positive, I will do what I can to get you on a trial to change your therapy. But a large part of that is if insurance doesn't pay for it, they're gonna have to pay out of pocket. And sometimes we may not have a next therapy that we can give them. So that's the caveats to this. And the other caveat is that no test is 100% perfect. And especially
mm-hmm,
the negative predictive value is not there with most of the commercially available tests out there right now. I would say all of them really. And so a negative result does not mean you're cured. This is why companies say keep getting serial tests. It's not clear that
mm-hmm,
everyone's insurance or anyone's insurance is going to pay for these things. So that has
right,
to be taken into account, the financial toxicity. And these are all the issues and parameters that I talk with to my patients about because they have to enter this eyes wide open.
mm-hmm, right. There's a
The
lot of
reason I've
like,
even thought about offering this to some
yeah,
patients, one, I have expertise in this, obviously, since we're one of the first to really even show this in humans
mm-hmm,
back again in the mid 2010s, whatever. But also, patients always ask you, if this were you, what would you do? Right. And so as a scientist, I want data, even if I
right,
know it may be a fait accompli that this means I'm going to have metastatic disease at some point if I can't do anything about it. But that's just me. And so I will be transparent to you. I've had patients who, once I've explained to them, they said, you know what, I
mm-hmm,
want to order it. And
yeah,
so I think that's okay. We're in a gray zone right now. We don't know what is the right thing or wrong
right,
to do. And we may never know. This is another reason I
mm-hmm,
started thinking about offering the test because there are probably going to be some patients that are going to actually benefit. And yet, a clinical trial, unless it shows the majority of patients benefit or there's enough statistically
mm-hmm,
meaningful benefit, it will not get approved. And so one has to start thinking about this is different than drugs where the toxicity is real in terms of, you know, long-term side effects, short-term side effects, including death. This is actually a test. And so the toxicity is much more mental than it is physical.
mm-hmm,
And so we have to really think about all these parameters. To me, this is super exciting. It's an emerging field, something, again, my lab's been working on for well over a decade, and to see it to this point where we're almost at clinical utility is exciting, but there's still a lot of questions that we don't have answers.
Yeah. Yeah, definitely something to look forward for the upcoming months, I guess, or maybe next San Antonio to see if we
Yeah,
get
we'll see.
some. Yeah, that is definitely very, very exciting. I guess for the current fellows and trainees, do you have any piece of recommendation in terms of, we always want to like conduct research and look at questions. What are like, I guess, current themes, I guess, from the conference or just from your expertise that are still some questions that are unanswered or should be further looked into?
Yeah, I think this is for me, the fun of still seeing patients and the value of still seeing patients
Mm-hmm.
is that the fun is the part that the patients they are our constituents. That's who we're working for. The value for me as a scientist and a clinical translational researcher is what are the unmet needs? So when I was seeing patients at Hopkins, 20 years ago, and I'm sure you've all seen this with all solid tumor, the biggest unmet need in my mind is the question, is this patient cured or not? And therefore, are we undertreating when
Mm-hmm.
we shouldn't be, or are we overtreating? And in breast cancer, we overtreat a lot. We know that by our numbers. We just don't know who's cured and who's not, so we overtreat.
Yeah.
If we can solve that conundrum in any way, I think that's where me, as a scientist and a clinical translational researcher, really want to go towards and make an impact in patient care.
Yes, especially with the current keynote regimen, it would be great to have a biomarker and being able to like
Yep,
determine, like, do we really need to continue treatment
yep,
with pembro and or is there a, feasibility to stop at an earlier standpoint because we know there are adverse effects.
yep, absolutely, absolutely.
Awesome. Thank you so much for your time today. I really appreciate it.
Yeah,
And
no
hopefully
problem.
we will connect again next year and with a new exciting clinical utility update.
Sounds great. Thanks, Jasmine.
Awesome.